Hi, this is part 2 of the GU conditions. Next, we're going to go into an overview of prostate cancer and, prostate disease, which does include prostate cancer, epididymitis, prostatitis, a variety of things that we're gonna get into. So, BPH develops in over half of men older than 50 years of age, and most men 85 and older have BPH. When you self-reported prostate disease, when you look at the statistics on that, it affects about 3 million or more Americans. Prostate cancer is the second leading cause of cancer death in men, but many patients have asymptomatic or low-grade tumors. So what that means is that oftentimes they're going to die of something else before they succumb to prostate cancer. The prevalence of prostatitis is similar to that of ischemic heart disease or diabetes, so you can see it's very prevalent. So what is BPH? So BPH is it's hyperplasia, not hypertrophy, and so hyperplasia is the increased number of cells, whereas hypertrophy is the increased size of the cells. So there's urine flow that's restricted secondary to that large prostate. And BPH begins in the transition zone of the prostate, and it potentially obstructs the urethra. And they're not really exactly sure why this happens, but they do know that it is related to hormones. And then it begins with symptoms which can be either obstructive and or irritative. And it's a common cause of hematuria, and it's not cancerous. So let's take a look at some of the obstructive symptoms. There can be hesitancy, there can be a decrease in the stream amount and the volume. There can be an intermittent stream, so they pee a little bit and stop and pee a little bit more. There can be incomplete emptying, there can be dribbling. For the obstructive symptoms, it's estimated that about 1 in 10 men between the ages of 70 and 79, and then 3 in 10 men between the ages of 80 and 89 will have at least one episode of acute urinary retention. And then if that happens, what they do with that is they use alpha blockers to reduce that outlet obstruction, and then 5-alpha reductase inhibitors like finasteride, and that helps reduce the prostate size. So we'll talk about that in another slide. But the irritative symptoms are nocturia, frequency, urgency, dysuria. So some of the causes can be prostatitis, it can be narcotics, Benadryl, Sudafed, Ditropan, and excessive alcohol. So let's take a look at why. So prostatitis, it can increase bladder outlet resistance due to the prostate swells and there's some edema there. Narcotics can decrease that bladder contractility. And then diphenhydramine or Benadryl, which you all know is an antihistamine, it has significant anticholinergic effects, and so what happens, it can reduce that bladder contractility. Sudafed is a big offender. It can stimulate the alpha receptors in the prostate, and it increases resistance at the prostatic urethra. So, they can have retention. Ditropan, that's a very strong anticholinergic, and it's given for the treatment of bladder spasms and overactivity in urinary incontinence. So typically men should really not be given this medication unless it's supervised by a urologist. Detrol is a similar type of medication, and other urinary incontinence meds for like overactive bladder can also carry some of the same risk for that. And then excessive alcohol, like binging, it can trigger urinary retention. They don't really know exactly what the mechanism is. So looking at history, you're looking at if you want to get at the symptoms, one easy way to do it is use the International Prostate Symptom Score. It's called I-PSS. And they'll ask you, like, in the past month. It's a survey you can hand out to your patients, and they can fill it out. So in the past month, and it's a rating scale from like not at all up to almost always. It's and then you score it. And so, for instance, they get it like incomplete emptying. They might ask, how often have you had the sensation of not emptying your bladder? Frequency, have you had to urinate less than every 2 hours? And then they rate it. So the scoring on that is you can get from 0 symptoms all the way up to severe. Severe is 20 to 35. Mild is 1 to 7. So 1 to 7 is mild, 8 to 19 is moderate, and 20 to 35 is severe. They also ask you about quality of life symptoms on there too. And there's just one question on that. If you were to spend the rest of your life with your urinary condition just the way it is now, how would you feel about that? 0 is delighted and 6 is terrible. So it's really a nice scale to use. It does a lot of work of the work for you. In the exam you're going to do, you're going to check the abdomen. You're going to check to see if there is any bladder distension there. And then one other thing I want to say with GU, with the digital rectal exam, blood or BPH develops in the transition zone of the prostate, and that surrounds the urethra. And so the urethra, which goes through the prostate, and it's the enlargement of the prostate near that urethral lumen that results in the urinary symptoms. So while many men with BPH have large prostates, a DRE is not really a very accurate means by which to assess the severity, because the obstruction is around the urethra. So anyway, size does not correlate to symptoms. The consistency of the prostate would be smooth and rubbery. It may or may not be symmetrical, and you might have nodules on it. And again, the DRE for the exam, it should be non-tender with this. Some of the labs or diagnostics you might do, you certainly want to do a UA and CNS. You're looking for any, causes for like infection that are treatable, hematuria, or, maybe somebody has diabetes and that's why they're having the symptoms. The other thing is looking at a PSA, drawing that only if you have about 10 or more years life expectancy, and the diagnosis of prostate cancer would change your management or treatment. So, if it's somebody that's 85 years old, you're probably not going to do this. You're not going to probably change anything. You also might look at the creatinine to see if there's any obstructive issues or also renal disease. And then BUN is normal for this. Also, you might, in most people, you would send on to urology at this point, but you might do an abdominal ultrasound to rule out any pathology or any kidney issues. And urology is the one who's going to do more of the testing. They can do post-residual void, uroflowmetry, and so forth. So some of your differentials you're looking at is bladder cancer, prostate cancer, infections we mentioned before, including prostatitis, cystitis, and then also if there's any kind of stricture. And looking at non-urological, so they have the symptoms because they have maybe MS or Parkinson's or CHF, some of those kinds of things. So some of your treatment options is watchful waiting. So like if you use that scoring tool, and if it's 7 or less, you're probably not going to do anything. The other thing is if the patients, they might have a score of 15, but it's really not bothering them, then you're not going to do anything. There are medications, we'll go through those, and then surgery. Obviously, then you're going to refer. So some of the things you're going to start with first are some of the lifestyle management. And it's also, your management is driven by the impact of symptoms for the patient and also the patient's quality of life. So you're going to try to reduce nighttime fluids so that they don't have to get up so much. So like no fluids after they eat dinner. Also eliminating the bladder irritants such as caffeine, alcohol, or nicotine. And then avoiding drugs that aggravate any symptoms. So we'll go through a few drugs in a little bit. But, sometimes with these interventions, it's enough to manage mild symptoms, and you just reassure and you assess, as appropriate. So here's a table that you can look at. Alpha blockers is usually where they start. It relaxes the tension in the prostate smooth muscle, and it targets the alpha receptors. So One of the side effects can be from this dizziness. That's can be one of the common ones. There can also be erectile dysfunction. Headache is another one that sometimes people talk about. Fatigue as well. So, and it has the dosages listed for you. And then there's subtypes of the alpha androgenetic receptor targets, and that and those are like Proscar. Those take a lot longer to be effective. So we'll talk about that in a second. We'll go to the next slide. So here's your alpha blockers and your subtype alpha 1A androgenetic receptor targets. So Flomax, you want to take it, you instruct them to take it 30 minutes after the same meal. So if they take it at breakfast or they take it at lunch or supper, it should be that same consistent meal. Uroxetrol, that one you have to take immediately after the same meal each day. So there's if you want to have the best effectiveness, you should educate your patients on this. And then the onset can be in about 2 to 4 weeks on the latter, whereas the ones on top, if there's urinary retention, you're going to go to the alpha-1 blockers first if you need to have quick results. So the Proscar and Advodart, that actually helps shrink the prostate. It actually decreases the PSA, and then another benefit could be help with male pattern baldness. But again, educate your patients. It's not a quick fix. So when you're using these, also you go to these after the first step isn't working for you. Also, if they have really large prostates, that's another one. And then also prevent disease progression. So some of the side effects, erectile dysfunction, while it's a low amount, you still, if a person still is sexually active, you want to be cognizant of this. So let's talk a little bit about prostate cancer. So the incidence increases with age. It's rare in men that are younger than 40 years of age. African Americans tend to have this happens. They have a higher incidence, and it happens at an earlier age. They have a higher mortality, and oftentimes by the time you diagnose it, they have more advanced stages. Family history is also a contributing factor. Men with one first-degree relative affected have more than a twofold increased risk. And then diet high in fat consumption also is with a higher risk. So frequency of disease varies in different parts of the world too. It's high in North America and European countries, but it's intermediate in South America. And it's very low in the Far East, so they think could be environmental or dietary etiology to this disease. And it's a most common non-cutaneous malignancy in men in the U.S. And there's about 218,000 newly diagnosed cases each year, and there's about 27,000 deaths annually. So guidelines kind of go back and forth on this. So as I'm taping this in 2019, you're going to want to always check to see what the guidelines are. In the last few years, this has flipped back and forth, actually, because a lot of the different associations are like the urologists versus the United States Preventative Services Task Force versus the American College of Physicians and so forth. Everybody kind of has a little bit of different things. So the USPSTF changed not too long ago, where they said middle-aged men age range 55 to 69. They recommend that you discuss the potential benefits and harms of screening to undergo PSA screening, and that should be individualized. It's a grade C. And then they recommend, if you're 70 or older, to basically stop screening in this age group. And it's a D recommendation. So you can see the other ones there. But again, you always want to check to see. So most patients, especially those in early stage, and that's a very curable, stage. Most of them are asymptomatic, and so the direct activation of the urethra and bladder, if they have disease in that area, you could have frequency dribbling, nocturia, incontinence, and hematuria. And then if it evades and there's an extension of it, you can have impotency, and you can also have pelvic pain. And cancer usually arises in the peripheral zone of the prostate, and then the cancer can spread by 3 different routes. It can extend by the direct extension, moving into the next area. It can go through the lymphatics, or it can go through the bloodstream. An advanced disease also can include compression of the spinal cord from metastases. You can also have DVTs, emboli, pulmonary emboli as well. So the GU exam, the DRE, the prostate may be normal or stone hard irregular with fixed nodules. It can be non-tender. Cancer is non-tender. And that median sulcus can be obliterated, so you don't feel that. A digital rectal exam is an effective screen because the majority of prostate cancer develops at the periphery of the gland near the rectal wall where it can be palpated. So I just kind of thought that was interesting. Also, you might, in the abdomen, there might be some bladder distension, there might be some lymphadenopathy, inguinally present. And then labs, PSA, not specific. 40% have prostate cancer, have normal values. Your values do increase with age. So evaluation and referral. So if the PSA level, sometimes people will watch that for a little bit to incremental draws to see if it's kind of staying there, if it's increasing. If you have abnormal DRE findings, you certainly want to refer to urology. And then there's a whole host of different things that they can do. They will score it via Gleason score and follow it that way. So anyways, we're not going to get into this because that's through referrals. So now we're going to move into prostatitis. That's the inflammation of the prostate gland. You can have bacterial, you can have chronic, it can be acute or chronic bacterial, and then it can be a non-bacterial cause, which is most common. More than 80% of patients with prostatitis have no identifiable infectious agent. If you're younger, you have to be concerned about STIs, and gonorrhea and chlamydia are the most common, so you always want to check, because then you would treat based on the STI guidelines. Chronic is more common in patients older than 50 years of age. Also, athletes who run a long distance and have vigorous exercise regimes, they can be predisposed to prostatitis, although they don't really understand the etiology of that. But also heavy lifting. I worked in a clinic where there was a urologist that came in like one time a month. It was a underserved clinic. And he said he used to see patients, guys that would come in right after a heavy snowstorm because they would be out shoveling to make some money. And anyways, they'd end up with a flare. So some of the risk factors are age older than 50, history of a previously diagnosed UTI. Also, chronic prostatitis can be associated with a history of recurrent UTIs. And as I said, men usually don't get UTIs. Those are complicated when you're looking at treating it. And with recurrent UTIs, with chronic prostatitis, they think there's a repeated seeding of the urinary tract by the infected prostate. So causes usually gram-negative bacteria, especially E. coli. And some of the non-bacterial, you can see, chlamydia, that's there. And then symptoms may include, not always do you have a fever or chills. You can have low back pain, perineal pain. There can be a pressure down in that area that guys will describe. There can be the LUTS, the lower urinary tract symptoms of like you're going to have a urinary tract infection. Also with BPH, with some of the nocturia. On exam, it's going to be, that prostate's going to be tense, it's going to be boggy. You got to be really gentle with this exam. Sometimes people will treat without even, not in urology, but in primary care, I've seen that before. Because the prostate's so exquisitely tender, it can be warm, enlarged, firm, or regular. And then urologists might do a massage of the prostate, or if you're working in a specialty, you might do that, but most primary care people don't do this. If there's a prostate massage, you don't order a PSA at that time. And for labs, you might look at CBC. Obviously, you want to do a UA and a CNS. So let's look at chronic. There's various degrees, and again, this can be obstructive or having irritative, voiding symptoms with this. There can be lower abdominal pain. There can be a pressure in the genital areas with some penile pain. On exam, the prostate can feel normal or it can be boggy. Sometimes people do like 3 sequential urine samples where they measure the amount of urine, and then the second sample of any discharge after a prostate massage. Again, this would be like urology. And then they do a final sample of urine after massage. And so they're looking at leukocytosis as, being present. The other thing that they're going to do is in the outpatient area, you're going to be treating this. So for acute, and I'll tell you that I've seen different lengths of time, so you might want to, not everybody does it the same, but for acute, usually Cipro, 2 to 4 weeks. It can be extended if needed. I've seen that before. Bactrim or Doxy, those are some of the ones that you would use. Again, if there is a concern about STIs, you're going to follow guidelines for that. Chronic is longer, 6 to 12 weeks. They might also use a quinolone or Doxy. Usually this is a referral. Sometimes they'll do biofeedback and then the surgery. Again, for like non-bacterial prostatitis, you could do NSAIDs, and then you also would be doing potentially medications to shrink the prostate if that's an issue. So like Proscar you might be using. And then, let's see. The other thing for alternative, you might use like warm sitz baths might be helpful, or whirlpool baths. Sometimes people use some herbals such as zinc or saw palmetto, pumpkin seed oils, essential fatty acids, and whether they work or not, and what efficacy is there. Saw palmetto has kind of gone in and out of favor. Also, they might use anxiety treatments such as meditation or biofeedback. And moderate exercise can be helpful too. Moving on to epididymitis and inflammation of epididymis. You can have squirrel pain. There can be marked swelling. There can be induration of the posterior lion epididymis. And then there also can be inflamed testicles that can almost look like orchitis. I had a patient like that in clinic where his testicle was so large, I sent him to the ER because it was so exquisitely painful. I really thought he had mumps. Anyways, it turns out that it was epididymitis, but it was just a severe case. So some of the epidemiology and causes can be, a new sexual partner. They might have an STI, unprotected intercourse. There might be a history of UTIs with dysuria. You might have urethral discharge with this. And again, it might have been caused by some heavy lifting or straining. Chlamydia is the major cause in sexually active heterosexual men under age 35, and that accounts for about 70% of the cases. You have gonorrhea in some of the majority of the remaining cases. Some have both infections, and sometimes too you can get Pseudomonas in men over age 35 for a cause. Some of your symptoms: swollen testicles, scrotal edema, pain. You can again have urinary tract symptoms, fever, chills, malaise, and low back pain. So exam, edematous scrotum, enlarged painful testicle. You might have some discharge, and then you have a positive Friend sign when you lift the scrotum up to the symphysis pubis, and then you get relief. The patient gets relief from it. That's called a Friend sign. So some of your diagnostic reasonings you want to do a UA and a culture and sensitivity, and STI testing if warranted. You can do an ultrasound of the scrotum if you need to confirm the diagnosis. And then medical management. If you're younger than 35, you're going to be usually treating for STIs. If you're older than 35 without a STI, usually E. coli is the most common. Sometimes you might have pseudo or staph there too. Usually you're going to do a quinolone. You might do levo or cipro for 10 to 14 days. Also analgesic 6 baths and elevate the scrotum. Treatment is rest to support the scrotum. Sometimes they'll wear jockey short underwear. Moving on to erectile dysfunction, ED, and this is inability to achieve or maintain erection. Every time you watch a sporting event, I can't count how many ED commercials. They spend a lot, Big Pharma spends a lot of money in that area. So they can't achieve or maintain erection. There can be a lack of sexual desire or inability to ejaculate. So organic causes is about 80%, whereas it's a psychological in about 20%. Also, this is a window to a vascular system. So if somebody has like diabetes, has coronary artery disease, uncontrolled hypertension, some of those kinds of systems where the vascular system has been compromised, this truly is kind of a window into that system. So all men, occurs in about 50% of all men at some time in their life over the age of 40. And so, basically with that organic, they're just not getting enough blood flow to the area to achieve an erection. So one thing you want to ask about relationships, you're going to kind of delve into, about that, looking at that psychosocial area as well. Is it a happy relationship? Are you monogamous? Are you have the ability to obtain or maintain an erection? Or do you have a premature, or you don't have any absence of emission, or you're just never are able to come to an orgasm? Also, you want to look at medications that can cause impotence. And so diuretics, antihypertensives are common, antidepressants, antihistamines, alcohol, and some of the illegal drugs. There's a whole host of things that can go into this. You look at the SSRIs, a lot of times if guys need to go on those, that's one of the things that you might want to consider, looking at the classes that you can use. And then risk factors, some of the ones that I mentioned before, but I didn't mention smoking. But that is a huge thing. Also, as far as if I have a person who has ED and they're a smoker, that's one thing I do counsel them about. And so for the presentation, for the exam, you're going to do a male GU exam. You got to check too if there's any feminization, such as gynecomastia, or if there's any abnormal body hair, where there's issues with, you think the testosterone levels might be off. Also, all pulses should be palpated because that's a vascular system. So labs, you also want to make sure they don't have diabetes, have a thyroid issue, or have elevated lipids. And then if you're going to do a testosterone level, you do it in the morning. If the testosterone level is below 300, then you do a serum prolactin level. It's warranted. So here's an erectile dysfunction algorithm. Actually, this just came out in 2018. And this counsels the man and the partner regarding, and it talks about the psychosocial kinds of things, the importance of lifestyle, such as weight loss, exercise, and smoking cessation to improve erectile function. I think that's a big one that sometimes people don't counsel enough on. And then they also encourage you to talk about the benefits and risk and burdens of the ED treatments that are not contraindicated. And they talk about it should be a shared decision-making model regarding if you're going to use medications or vacuum devices or have more types of invasive procedures. But normally you're going to treat with a PDE-F inhibitor medication. And so some of those inhibitors in this chart, Viagra, Cialis, Levitra, and so forth. Prior to any use of these, you may have to make sure there's a complete urological workup to rule out any other diseases. very important. So one thing I did want to mention, that one thing you need to be when you counsel patients, look at the onset of action, how long it takes, and then also look at how long that half-life is. I mean, Cialis has a really long half-life, 17 and a half hours, but onset of action is, an hour to 2 hours. Whereas on some of the other ones like Stendra onset is 15 to 30 minutes, and its half-life is 3 hours, so duration is up to 6 hours, whereas Cialis is up to 36 hours. So another thing to look at is effect of food. This is really important because on Stendra and Cialis, food doesn't affect it, but if you're on Viagra, Levitra, high-fat meals decrease efficacy. So somebody's out on a date and they're, have their, they're out and they're having a big, meal, and they have a high-fat meal, and they take a Viagra and they expect it to work, it decreases the efficacy. So some of the unique side effects, I just thought I'd bring this up for the vision abnormalities for Viagra and Levitra. So I just, if I can read this for you, it says that it has been observed that Viagra that in high doses can cause transient visual disturbances in otherwise healthy subjects, including blurred vision and photophobia. The active ingredient in Viagra, sildenafil, works by inhibiting the phosphodiesterase 5, which in turn leads to vasodilation. But it said it could also exert effects on PDE6. That's an enzyme with a key role in the phototransduction pathway, which could leave some users at risk of potential vision problems. Sildenafil could also potentially exert adverse effects on heterozygous carriers of a recessive allele that causes retinitis pigmentosa. So I just thought that, I believe the PDE6 is in that enzyme is found in rods and cones in the eye. So anyways, I just thought I would mention that that's really what that is about the vision issues. So some of the more common ED medications, I talked about the medications before, but also testosterone replacement. There's patches and gels, and then here's some of the dosing here, but on the inhibitors. But you don't want to give those inhibitors to anybody if they're on any nitrates, because it's really going to bottom them out. It'll lower their blood pressure, and it'll cause syncope. And so you want to double check and make sure that all the contraindication boxes are checked off. So for education, you want to stress the importance of management of chronic conditions such as the diabetes, hypertension, stress, those kinds of things. You can also use guided imagery for if it's psychogenic. Make sure they lose weight, stress, yoga, those kinds of things. Have a really good control of blood pressure, and then you may need to refer if there's issues. But the other thing is that when you're using some of the drugs, the person also has to have some desire in order for it to work. So counseling can be needed if that's an area that's problematic. So let's move on to testicular pain and some of the differential diagnosis. Some of the causes of pain. You can have edema or swelling of the epididymis or the spermatic cord. Testicular torsion, that's a surgical 911. They're going to show up in the ER. You can have a spermatocele. That can cause some pain, although most of them really truly are painless. And then a varicocele, which is like a varicose veins. It's feels like a bag of worms. That's not painful. So hernias, hydrocele, and hematomas all have to be excluded. You want to get a detailed history, and physical exam will direct the assessment to exclude other diagnoses. So epididymitis, prostatitis, and then pain from prostatitis, usually that's in the lower back, and it can radiate to the testicles, and sometimes it will have a fever. And so you can get a scrotal ultrasound to identify any mass originating in the testicles. It's non-invasive, and the pattern reveals the presence of a hypoechoic mass, and it's distinct from the surrounding normal testicular tissues, spermatoceles, hydroceles, or varicoceles. So let's look at torsion. You can see that picture that the spermatic cord is just really twisted. Mostly found in younger individuals, 12 to 18. Sometimes, usually it's a left side. It's more common because it's the longer spermatic cord. And ischemia can set in with as little as 6 hours, but it's so painful, because the blood supply the supply is really cut off. So most people are into the ER pretty quick. They can have edema in the area. It can, have a high riding testicle. You don't have urinary symptoms. You have lack of cremasteric reflex. That's where, do you remember from health assessment, you stroke the thigh, and on the same side, the inner thigh, and on the same side, the testicle should rise. So that friend sign, it's a negative friend sign, which is not really reliable. So like if you take the scrotal sac and then you put it up onto the abdomen, the pain will still be there. So the pain will still be there. So medical emergency, surgical referral. Hydrocele, and that's a fluid collection between the parietal and the visceral layers of tunica vaginalis. It doesn't cause any pain. It's palpable and, palpable mass around the testes. The testes are not palpable. If palpable, it's probably a hernia. You can transilluminate. You can see how you put the light source up, and you can see the glow there. And then you may do an ultrasound to rule out whether it's cancerous or a hematocele or some other kind of issue. And they may or may not do surgery depending upon the size. So varicoceles, that's like dilation of those testicular veins. So you can see 10% on normal males, 30% they have fertility issues. I had a friend whose husband had one, and he went and had surgery, and then they didn't have any problems after that, but left oftentimes more than right. Feels like a non-tender bag of worms. You get an ultrasound, and then they can do their surgery. Moving on to urinary incontinence. This is involuntary loss of urine from the bladder. It is not a normal part of aging. It can be common in older men due to enlarged prostate, and there can be about over 50% of women over age 50 have complaints actually of urinary incontinence. Most women do not seek help for this, and you can have transient, which is a sudden onset, and then there's usually a specified cause for it. Something triggered it, something like delirium, or there was an infection, or some kind of medications or something like that. Transient, you can fix. Persistent, it's more categorized, and then it's stress, urge, mixture. There's functional. You'll find different categories. There's overactive bladder, which is urge incontinence. Overactive bladder is not found in stress incontinence, so they have all different classifications on that. So prevalence, about 15 to 30% of community dwelling older adults are affected by this. About 60 to 70% of residents in long-term care institutions. And then as you age, the risk goes up with this, and it affects more women than men until age 80, and then it's about equal. Incontinence is also a significant problem for your caregivers, and it's one of the main reasons for admission into nursing homes. So, let's see here. So, types of urinary incontinence. So you can have an urgency incontinence, and that's an involuntary loss of urine associated with urgency. It can be sudden, and you have this compelling desire to go to the bathroom, and you can't really defer it. It's really, it's a really strong sense of urgency. And then you can have stress, and that can be any type of physical effort where you have like coughing, sneezing, exercise, those kinds of things. Mixed incontinence, you can have leakage associated with both urgency and physical exertion. And overflow can be due to incomplete bladder emptying. So some of the comorbidities that can be caused or that can affect incontinence, these are a list and you can take a look at those. Meds associated with urinary continence, that's another you can kind of take a look at. And when you think of older people, look at how many of these medications older people are on, which can certainly be problematic. There's a Beers list, Beers. It was Dr. Beers, he's passed away, but for elderly, that's a great tool that you can go and look up what medications have effect on what systems for elders, and they have medications that are better that you should prescribe and ones that you truly should avoid. And then here's just an algorithm for incontinence. This one was in, I know it's probably hard to see, but you'll find many different algorithms, and I'm sure your book has one too. So some of the screening classifications, I think these are good to use. There's only like 4 questions here, which is very helpful. Do you leak urine most often when you are performing physical activities such as coughing, sneezing, lifting, exercise? That's stress. Do you have the urge or feeling that you need to empty your bladder but can't get to the toilet fast enough? That's urge. With both physical activity and a sense of urgency, that's a mix of the above two. And then do you leak urine without physical activity and without a sense of urgency? And that's something else. So let's look at screening. You want to talk about history, including quality of life. You want to ask about there's screening tools out there that you can use that walks you through, and the patients can fill them out while you're looking at their record or whatever. But also then the physical exam, you want to look at cardiovascular, abdominal, musculoskeletal, neurological, and genital urinary exams. Testing, you're going to do talk about a bladder diary with the patient. A stress test, that's drinking fluids and then having them cough, see if they leak. Urinalysis, and you might get labs for kidney functioning. And optional post-void residuals or urodynamics, other lab tests usually, or somebody else is usually going to be doing those. So testing a bladder diary, very helpful for patients who have nocturia. That way you can see how much they're drinking, what times during the day. So they have to record all that. They should keep it for 2 to 3 days. And then also document any episodes where they had incontinence. You might need to give them a hat so that they know how much they leaked. And then if they have wear undergarments, then you're going to have to talk to them about, drops, teaspoons, tablespoons, and so forth. And then labs, you want to check a UA, you want to look for any hematuria, and you can also look for any undiagnosed diabetes or uncontrolled diabetes. You're also looking for diagnosis of UTI. It requires additional symptoms. So just because they're incontinent doesn't mean they have a UTI. Again, don't treat asymptomatic bacteria unless there's certain populations, and we mentioned one of them was pregnancy, but if it's an older adult and they don't have anything else except asymptomatic bacteria in their urine, you don't treat. So it's a stepwise management. So lifestyle changes would be first, and then behavioral therapy such as bladder training and pelvic training, bladder training, pelvic training, physical therapy, and then different devices, weight loss if you're overweight, and then drugs, and then surgery. So lifestyle management, weight loss really decreases stress and urinary incontinence. Extreme fluid intake, if they have less than 32 ounces or more than 64 ounces, that's one thing you want to talk with them about, and especially when are they drinking it? Is it all after supper or like right before they go to bed? Also, you want to limit those caffeinated beverages because it increases urgency and can irritate the bladder. limit alcohol, evening fluid, we talked about that. Quit smoking. Chronic cough can cause stress incontinence. And then if they have an issue with constipation, because it puts pressure on the bladder and causes urethral restriction. So let's talk a little bit about urge. So urge really is, it's really overactive bladder. It's detrusor overactive due to bladder irritation. It can be from cystitis, stones, or cancer. It can be from loss of bladder inhibition. So if somebody had a stroke or somebody had a spinal cord injury, they can have urge incontinence. So it's a strong desire. The bladder is contracting when you don't want it to contract. And most often the symptoms include urinary frequency, nocturia, enuresis, and they're voiding large, moderate to large amounts. And so if you have overactive bladder, they might complain of urgency with or without incontinence. An individual with overactive bladder also complain of frequency and nocturia. And so physiological changes associated with aging make older adults particularly prone to this type of urinary incontinence. And so what do you want to do about it? You can do some of that behavioral would be prompted and scheduled voiding. You want to look at your fluid intake management. Lifestyle, you want to look at weight loss. You want to urge distraction if possible. And then medications. So some of the medications, medications don't necessarily solve this problem. Sometimes people have more side effects going on these type of medications. So anti-muscarinic agents are moderately effective for urge, overactive bladder, and mixed incontinence, and in men with urgency and urge associated with BPH. But there's contraindications with patients with narrow angle glaucoma, if you have impaired gastric emptying, maybe from diabetes, or urinary retention. These are totally contraindicated. So BPH, this could be an issue if they have the restrictive kind, the obstruction. And then, so you might be, if you're in a urology office, you're going to do a post-void residual. It's not necessarily, but anyways, you would check this if they're complaining of worsening incontinence while they're on medication. So here's an example of some of the meds for you, and you can take a peek at those. There's patches and pills and so forth. So let's go on to stress incontinence. Stress incontinence, involuntary loss of urine. It's with intra-abdominal pressure, and sometimes there'll be complaints of small amounts of daytime urine loss when you have physical activity. So somebody's like in a boot camp fitness type of exercise where they're doing high energy, high intensity workouts, coughing, sneezing. It's more common in women, but men can experience after they have a prostatectomy. So the bladder's leaking when you're moving. And basically there's a loss of structural support of the bladder, neck, and the urethra. So it can be associated with vaginal childbirth, obesity, also menopause because of low estrogen, and also advanced age. So the bladder's not contracting, it's just that intra-abdominal pressure. So, and you don't have nocturia. This is the only incontinence that you do not have at night. There's no nocturia with stress, unless I suppose you had a full bladder and you were coughing, you had a bad, bad respiratory infection or something. But otherwise, you're not going to have nocturia. So what's the management for this? So you can do Kegel exercises, and that's, you basically tell the patient, the woman, to squeeze the pelvic floor muscles. And so I always say, so pretend like you're sitting on the toilet and you're peeing, and now you want to stop that flow of urine. And then you hold it for up to 10 seconds, and then you release it. And you try to ask them to repeat it 10 to 20 times in a row, and you can do that 3 times a day. So that's how you instruct them. I guess there's some people, if they had really severe cases, they could have surgery, but this typically is not one that people have surgery for. So moving on to overflow. Oh, I should also say back here, I didn't mention biofeedback. People can do that. Weight loss really helps with this. So if you get people to do some exercise and decrease the amount of calories they're having. And then also if they're on diuretics, if you can lower the dose if possible. Sometimes people use a pessary. They'll get fit for that, or last resort surgery. There's controversies I've seen where people said estrogen may help, and then other people said it wouldn't. So I guess that's still out. And then overflow incontinence, and that is a involuntary loss of urine, and because the bladder is overdistended, and it can be caused by an underactive detrusor muscle or bladder outlet obstruction, leading to overdistension and urine overflow. So people who have overflow are typically people who have BPH, they have diabetes, they have Parkinson's disease, they have a spinal cord injury, diabetes, they have neuropathy, neurogenic bladder. And then also people who have BPH because it's a bladder outlet, it's obstructed. So some of the symptoms are urine, there's dribbling, like for men I'll ask, do you have any staining of urine in your underwear? They also feel unable to empty the bladder completely because they retain some urine. They have frequent leakage of small amounts, but they also have retention. So it's a high residual volume. There's nocturia with this. There's urinary hesitancy. There's no detrusor contraction on this. It's just overflowing. And they have urine loss without a recognizable urge. It can be a very uncomfortable sensation of fullness and pressure in that lower abdomen. So bladder catheterization is really what you do. And if there's anything that you can treat for the underlying cause, you can go treat it. Again, you can also have mixed types of this as well. So management, you want to treat the underlying cause, reduce or stop drugs that impair detrusor contractility or increase urethral tone. Also, if there's constipation, treat that. You might have to do intermittent catheterization. And also the last resort is protective garments, but they certainly are making a lot more products in the protective undergarments, and they see a market with the baby boomers aging, and before there was Depends, and now there's all these different fancy types of pads, and it's made it easier for individuals to wear them. So urology referral, you always want to refer to urology if there's an uncertain diagnosis. Also, pelvic organ prolapses, like somebody has a cystocele or rectocele that might need repair. Incontinence with new onset neurological problems, that certainly is something that you would want to refer. If somebody has recurrent UTIs, you just keep treating them, like for women. But for men, again, they don't typically have UTIs. That's one thing you would refer. Also, if you have treatment failure, you just don't seem to be able to eradicate so you got to check out what's going on. If they have that obstruction, that can be an emergency and significant BPH. And also, if you have persistent hematuria or proteinuria, you definitely want to refer. Don't just blow that off. You do want to refer to make sure that there's not like cancer there or kidney damage. Thank you.